Emergency Medicine Survival Guide. Everything you need to know before day 1 of your M3 Emergency Medicine Clerkship. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Welcome to the Emergency Medicine Survival Guide. Whether you end up going into EM or not, this clerkship will teach you something no other rotation can: how to think fast, triage effectively, and manage undifferentiated patients walking through the door. Emergency medicine is the front line of the hospital. You will see everything from chest pain and strokes to lacerations, psychiatric emergencies, and traumas. The pace is fast, the acuity is high, and you will learn to be comfortable with uncertainty. Even if EM is not your future specialty, mastering the approach to acutely ill patients will make you a better physician in any field. This rotation builds your clinical reflexes and teaches you to prioritize what matters most when time is limited. The week before you start, get your gear together and do some focused prep reading. Your white coat pockets should have a pen light, trauma shears, your stethoscope obviously, a small notebook or pocket card with normal vitals and common drug doses, and a phone loaded with key apps. Download MDCalc for clinical calculators like the Heart Score, Wells Criteria, Picarn, and Ottawa Ankle Rules. Get the Epocrates or Lexicomp app for drug dosing. If your program uses one, download the EMR app so you can look up patient charts on the go. For reading, skim through Tintinalli's Emergency Medicine or at minimum read Case Files' Emergency Medicine, which walks you through 60 high-yield clinical scenarios. Rosen's Emergency Medicine is the gold standard reference, but is massive, so use it selectively. Review a CLS and BLS algorithms because you will be expected to know them. Brush up on EKG interpretation, especially STEMI patterns, and make sure you can read a basic chest X-ray. On your first day, arrive at least 15 minutes early. The ED never stops, so there is no formal sit-down orientation in most places. Find the charge nurse and introduce yourself, then locate the attending and residents you will be working with. Say something like, "Hi, I'm the medical student starting on EM today. I'm excited to be here. How would you like me to pick up patients?" That last part is key because every attending runs their ED differently. Some want you to see patients independently and present afterward, others want you to go in together. Ask and adapt. Know where the supply room is, where the crash carts are, and where to find suture kits and splinting materials. Dress code is typically scrubs with your white coat, but confirm with your coordinator. Most EM shifts are 8 to 12 hours, and you may rotate between day, evening, and overnight shifts. Get your schedule early and plan your sleep accordingly because shift work is the hardest logistical challenge of this rotation. The team structure in the ED is flatter than most rotations. The attending is running the show and directly supervises everyone. There may be EM residents at various PGY levels, and sometimes off-service residents rotating through. There is often no fellow unless you are at a large academic center with subspecialty fellowships like toxicology or ultrasound. You'll also work closely with nurses, techs, pharmacists, and social workers who are absolutely essential to ED operations. The attending expects you to be efficient, communicative, and honest about your skill level. Residents are your best teachers for procedures and workflow. Treat everyone on the team with respect because the ED is a high-stress environment and teamwork is what keeps it running. A typical ED shift does not follow the predictable schedule of other clerkships. There are no morning rounds or afternoon lectures built into your clinical day. You show up, get sign-out on any patients being carried over, and then start picking up new patients. The flow goes like this. Check the track board for new patients, grab a chart, review the triage note and vitals, go see the patient. Do your history and physical, come back and present to your attending, put in orders together, and then reassess the patient as results come back. Rinse and repeat. You might see 4 to 8 patients per shift depending on complexity. Between patients, write your notes, follow up on labs and imaging, and look for procedures. Some programs have dedicated teaching sessions or conferences, so attend those whenever possible. Eat when you can because there is no protected lunch break. Study on your days off, not during shifts. When your shift ends, give a solid sign-out on your patients and head home. If you are finding this helpful, please like, subscribe, and hit the bell icon so you do not miss future videos. Pre-rounding does not exist in the traditional sense on EM, but you do need to efficiently work up a patient before presenting. When you see a new patient, get the chief complaint and vitals first. Then do a focused history using the OPQRST framework for pain or the standard HPI approach. Your physical exam should be targeted to the complaint. The EM oral presentation is much shorter than internal medicine. Lead with a one-liner. This is a 55-year-old male with a history of hypertension presenting with acute onset chest pain. Then give a concise HPI in about 30 seconds, hit the relevant positives and negatives on exam, state your differential, and propose a workup. Your attending does not want a 10-minute presentation. They want to hear your thought process in 2 minutes or less. Always lead with what is going to kill the patient first. Think about dangerous diagnoses you need to rule out before considering benign ones. Your note should follow a similar structure: chief complaint, HPI, ROS, past medical history, meds, allergies, exam, labs and imaging, your medical decision-making, and the plan. Now let us talk about the core medical knowledge you absolutely must know for this rotation. The bread and butter of EM revolves around 10 high-yield presentations. First is chest pain. You need to know the workup for acute coronary syndrome, including troponins, EKG interpretation for STEMI versus NSTEMI, and the heart score for risk stratification. Know the deadly causes of chest pain: ACS, pulmonary embolism, aortic dissection, tension, pneumothorax, /pneumox/, cardiac tamponade, and esophageal rupture. Second is shortness of breath. Think about P using the Wells criteria and D-dimer, pneumonia, /pneumonia/, COPD and asthma exacerbations, CHF, and pneumothorax, /pneumox/. Third is abdominal pain. Know the classic presentations of appendicitis with RLQ pain, MAC Burney point tenderness, and CT findings. Understand cholecystitis, small bowel obstruction, ectopic pregnancy in reproductive age women, and AAA in older men with back pain and hypotension. Fourth is altered mental status. Run through a EIOU tips as your differential framework covering alcohol, electrolytes, insulin or hypoglycemia, opiates and overdose, uremia, trauma, infection, psychiatric, and stroke or seizure. Fifth is the approach to trauma using the TLS primary survey: airway, breathing, circulation, disability, and exposure. You'll be asked about this on every trauma case. The remaining 5 critical topics are stroke, sepsis, toxicology, cardiac arrest, and pediatric emergencies. For stroke, know the NIH stroke scale, the 4.5-hour window for IV TPA at a dose of 0.9 milligrams per kilogram with 10% as a bolus. And at large vessel occlusions involving the internal carotid or proximal MC, it can be treated with endovascular thrombectomy up to 24 hours in select patients with favorable perfusion imaging. The key phrase for stroke is time is brain, and the first step in any code stroke is a non-contrast CT head to rule out hemorrhage. For sepsis, know the sepsis 3 definition as life-threatening organ dysfunction caused by a dysregulated host response to infection. The quick SOFA criteria include respiratory rate over 22, altered mental status, and systolic blood pressure under 100, and a score of 2 or more should raise concern. Antibiotics should be given within 1 hour of shock recognition because every hour of delay increases mortality by 7 to 8%. Initial resuscitation includes 30 milliliters per kilogram of IV crystalloid and vasopressor therapy targeting a mean arterial pressure above 65 millimeters of mercury, with norepinephrine as the first-line vasopressor. For toxicology, know the common toxidromes. Anticholinergic presents with hot, dry, and red skin with dilated pupils and delirium. Cholinergic presents with sludge or dumbles, including salivation, lacrimation, urination, diarrhea, GI distress, and emesis. Sympathomimetic presents with tachycardia, hypertension, diaphoresis, and agitation, and opioid presents with pinpoint pupils, respiratory depression, and decreased mental status treated with naloxone. Key antidotes to know include N-acetylcysteine for acetaminophen overdose, flumazenil for benzodiazepines though used cautiously in chronic users, fomepizole for toxic alcohol ingestion, and atropine plus pralidoxime for organophosphate poisoning. For cardiac arrest, Know your CLS algorithms, including epinephrine 1 mg IV every 3 to 5 minutes. The distinction between shockable rhythms like ventricular fibrillation and pulseless ventricular tachycardia versus non-shockable rhythms like asystole and PEA. And the H's and T's of reversible causes including hypovolemia, hypoxia, hydrogen ions, hypo and hyperkalemia, hypothermia, tension, pneumothorax, pneumox, tamponade, toxins, and thrombosis. For pediatric emergencies, know the Picarne head injury rule, which identifies children at very low risk for clinically important traumatic brain injury. Pediatric vital sign ranges by age, the approach to the febrile infant under 60 days old, which requires a full sepsis workup including blood culture, urinalysis, and lumbar puncture, and pediatric weight-based dosing for common medications. Procedures are a major part of this rotation and a huge opportunity for you. Common procedures you should try to get include suturing lacerations, I&D of abscesses, splinting fractures, IV placement, and if you are lucky, intubation and central lines. Volunteer aggressively for procedures. When a trauma comes in, ask to be part of the team. Practice suturing on simulation models or banana peels before the rotation. Learn the basics of point-of-care ultrasound, especially the FAST exam for trauma. Know how to do a basic wound assessment and when tetanus prophylaxis is needed. If your ED has a simulation lab, use it. Many programs will also let students perform lumbar punctures, reduce dislocations, or place chest tubes under supervision if you show initiative and competence. Learn the indications for each procedure so you can anticipate when one is coming. For example, if a patient presents with a paratonsillar abscess, recognize that an I&D is likely and offer to set up the tray. That kind of anticipation is what gets you invited back for more procedures throughout the rotation. Here is what separates students who honor this clerkship from those who just get by. Do pick up patients quickly and without being asked. Do present your differential and workup plan, not just the HPI. Do follow up on your patients and close the loop on pending results. Do volunteer for procedures and be ready when they come. Do communicate with nurses and techs and help with tasks like EKGs and blood draws. Do be honest when you do not know something. Now for what to avoid. Do not stand around waiting to be told what to do. Do not disappear without telling anyone. Do not be on your phone in the department. Do not present without a differential and plan. Do not argue with attendings or nurses. Do not leave without giving a proper sign-out. The attending evaluation in EM is heavily based on your clinical initiative, your ability to think through differentials, and how well you function as a team member. Enthusiasm and work ethic matter more here than on almost any other rotation. The Emergency Medicine Shelf Exam covers a broad range of topics. The NBME content breakdown emphasizes cardiovascular, respiratory, and GI systems at 10 to 15% each, with trauma and resuscitation and toxicology and environmental disorders each accounting for another 10 to 15%. Use ORALD and AMBOSS as your primary question banks and supplement it with Case Files Emergency Medicine for case-based learning. Tintinalli's is the definitive EM textbook, but use it as a reference rather than reading cover to cover. EM Board Bombs and the EM Clerkship podcast are excellent for high-yield audio review during commutes. Study the NBME content outline to identify gaps in your knowledge. Aim to do at least 500 practice questions over the course of the rotation. Balance your studying with clinical duties by using your days off for dedicated study blocks and doing 20 to 30 questions daily on shift days. Start studying from day one because this shelf covers a massive breadth of topics. Let us wrap up with a rapid-fire summary of everything you need to know. Before the rotation, load MDCalc and a drug reference app. Review a CLS algorithms and EKG interpretation and read case files EM. Your daily workflow is grab a chart, see the patient, present in under 2 minutes, order workup, reassess, and write your note. The top clinical topics to know: cold or chest pain and a CS, dyspnea/dyspnea/ and PE, abdominal pain and surgical emergencies. Altered mental status, trauma and the TLS primary survey, stroke and TPA windows, sepsis and the 1-hour antibiotic rule, toxidromes and antidotes, cardiac arrest and a CLS, and pediatric emergencies. Key procedures include suturing, abscess drainage, splinting, IV access, and point-of-care ultrasound. To get a great evaluation, pick up patients fast, always have a differential and plan, volunteer for procedures, communicate with the whole team, and never disappear without sign-out. For the shelf exam, use OWorld, Amboss, Case Files EM, and Tintinalli's. Aim for 500+ questions, and study the NBME content outline. Thanks for watching. Do not forget to like and subscribe for more medical education videos. Sources used in this video include Harrison's Principles of Internal Medicine 22nd edition, the NBME Emergency Medicine Subject Exam Content Outline, the 2021 Surviving Sepsis Campaign Guidelines, HASCLS Guidelines, Case Files Emergency Medicine, and Tintinalli's Emergency Medicine, a comprehensive study guide.